Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I am a general pediatrician and a proud JOMA member. And I'm really excited and really honored today to be interviewing Dr. Beinvogl. Dr. Beinvogl is an attending physician at Boston Children's Hospital and instructor of pediatrics at Harvard Medical School. Dr. Beinvogl completed medical training at the Technical University of Munich Medical School in Munich, Germany, and went on to do residency and fellowship in Pediatric Gastroenterology, Hepatology and Nutrition at Boston Children's Hospital and Boston Medical Center. Her clinical focus is on pediatric motility and functional gastrointestinal disorders. And along with colleagues, she has expanded the multidisciplinary abdominal pain program at Boston Children's Hospital. Her research is focused on identifying pathophysiologic mechanisms in irritable bowel syndrome, IBS, such as assessing the role of bile acids in pediatric IBS, as well as outcome research with a special interest in the multidisciplinary care of patients with IBS and other functional gastrointestinal disorders. So I heard Dr. Beinvogl speak at the Winthrop Pediatric Grand Rounds a few weeks ago, and I was blown away, and I loved it so much. I wanted to interview her. I listened to it again in preparation, and I could listen to it a bunch more times. She is phenomenal. So it's really a great opportunity, I thought, to be talking to her tonight. We're going to be talking about what used to be called functional gastrointestinal disorders. It's a very confusing term because really you're having dysfunction. It implies that it's different from disorders where you can pinpoint the problem more obviously, like strep throat, you do a strep culture and you see it's strep. These disorders, you will do blood tests or other kinds of tests and they will be basically normal. And yet the disorder is quite real. So we're going to talk about these disorders tonight. They are now called disorders of brain-gut interaction, shortened as Dgbgi, unless it's disorders of gut-brain, which would be Dgbi. Anyway, that's what we're talking about. And she's really a phenomenal speaker and a phenomenal interviewee. And I hope you enjoy. And again, if you want to hear different topics or possibly be interviewed, please reach out to us at health, HEALTH, at joma.org. Welcome, Dr. Beate Beinvogl. Did I say your name right?
Yes.
Good. Thank you so much for doing this with me. I'm so excited.
Thank you so much for having me.
I really appreciate it. And as I told you before, I listened to your talk at Grand Rounds and then again, and I could probably hear it a lot more times. It was amazing. And so we're going to talk tonight about disorders of brain-gut interaction, which blew my mind because I did not know it was yet renamed again. I knew it as recurrent abdominal pain and then functional, and at some point they called it psychosomatic. So what's up with all the names?
Yes. So most recently, disorders of brain-gut or gut-brain interaction is the correct label we use for a group of disorders that really are, in the GI world, disorders that present with symptoms, right? Like nausea, vomiting, abdominal pain, diarrhea, constipation, often very disabling symptoms. And if you do all the testing in the world, all that testing may come back or will likely come back negative. And yet those symptoms are very real. Mm-hmm. And so, we kind of think of it as a software problem in the body, right? We think about hardware problems being things like appendicitis, like Crohn's disease, inflammatory bowel disease, celiac disease, the kinds of things that we can relatively easily with our medical imaging and diagnostics can diagnose. But that's really only a small part of what can cause problems in our body, right? There's this whole other realm that we think about, or that I think of as sort of software disorders that affect the movement and also the sensors of the GI tract. And that those disorders are much more difficult to test for. In fact, there really aren't any good tests. which can be frustrating a lot of times for families, for doctors, because we love having tests, right? A test to nail down this is exactly what it is. But these disorders of gut-brain interaction are disorders that we don't have great tests for. And so a group of experts have developed a symptom criteria. And based on these symptom criteria, we can make these diagnoses. And the reason that they are now called disorders of gut-brain interaction is because we have learned a lot over the last 10, 15 years. A lot of research has shown that there are issues or abnormalities on all levels of this very complicated and complex communication system between the gut and the brain. And a disruption on any part of that axis and that communication line can cause the kinds of symptoms of disorders of gut-brain interaction. And, just to get a little bit more concrete, right? What are the kinds of diagnoses that we think about in disorders of gut-brain interaction? I might end up abbreviating it as Dgbi because it is a mouthful. Things like we sort of have the main groups of infant and toddlers, and things like rumination, cyclic vomiting, even infant regurgitation, right? The classic infant reflux that we as pediatricians or you as parents or general pediatricians see a lot. Those are sort of the infant, just a few examples of the infant and toddler disorders of gut-brain interaction. And then we have what we also see very commonly for children and adolescents. We group sort of the general disorders into functional nausea and vomiting disorders, abdominal pain disorders, and defecation disorders, with the most common ones being those that come with abdominal pain, right? Functional abdominal pain, irritable bowel syndrome, either with constipation, diarrhea, or functional dyspepsia, right? And I am happy to explain a little bit more about each of those diagnoses, like what they actually are. But the reason that we are trying to get away from these terms of functional abdominal pain, it's really dysfunctional abdominal pain disorder, right? Because these patients are not functioning. And so we feel like that's outdated in terms of the correct terminology based on the most recent research that we have.
Right. I think it's confusing because it sounds like it's all synonyms for it's all in your head, right? It's used to call it psychosomatic.
Yeah. Yeah. And that's actually, I'm glad you're asking that question because that's something that's very near and dear to my heart. I see many patients that come to me as a, pediatric gastroenterology specialist referred from other GI specialists or from general pediatricians, or some patients, find us at Boston Children's over the internet. And what I hear a lot is, I've been told it's all in my head, or I've been told, just because all the testing is negative, that's what they think I have, or, I'm making it up, or,
it's not real.
We can't find anything wrong with you, and so you have IBS. And so what patients feel very dismissed, right? They feel like they're not being taken seriously because they are struggling with that pain. And so exactly like you said, right? I really try to make a point because we know that the pain patients are experiencing related to these Dgbi is real pain. And we know that if you place, a patient with irritable bowel syndrome, for example, that's experiencing pain into what we call a functional MRI test, right? It's a magnetic resonance imaging device, an MRI, but it actually parts of the brain light up that are functioning at any given time. You will see a pain signal in the brain, right? It's not imagined. It's a true pain that they're experiencing. But the key is, right, that we are so used to always, whenever there's pain, we want to find a disease and the disease that explains it. And if we treat that disease, the pain goes away. And so we strep throat, you do a swab, it tests positive, you give antibiotics and it's gone, right? And this is very, very different from what we see in Dgbi, right? In Dgbi, what's wrong is the sensors in the GI tract, sometimes the movement in the GI tract. It's almost like you can imagine it as the pain itself being the disease or the problem, right? It's not an underlying disease that needs to be uncovered. It's really the abnormal functioning of the sensors, a constant false alarm that is causing the symptoms. And that's a very important difference and a point to understand.
Right. I love that analogy of the false alarm going off. And it's really analogous to a lot of chronic pain disorders, right?
Yes. Exactly. And, one of my favorite analogies that I think makes it very clear is, we've all been in a garage or in a parking lot where a car alarm goes off. And, you look around because it's a very loud, annoying, disruptive alarm. And most of the time, there's nobody breaking into the car, right? Most of the time, it's because somebody accidentally tried to open the wrong car or just touched it, and something about the car alarm was actually too sensitive. It didn't do what it's supposed to do, which is protect the car. It sort of gave a false alarm. And so it's very similar in Dgbi, that we have a similar sort of false alarms. So, a patient might eat a little bit and experience a lot of pain, or they might have chronic nausea, even though, they don't have an infection or they don't have any inflammation, or they may have, pain from just a little bit of distension of the gut. And so it's overly sensitive and sort of constantly firing all the sensors. And there's no, like in the car, right? There's nobody breaking into the car. There's no true reason for that false alarm, and yet it's going off, and it's extremely disruptive. It's extremely annoying. You want to hold your ears because it's so penetrating and present all the time. And that's exactly what patients are experiencing with chronic pain, including Dgbis, is this constant pain that can be very aggravating and disruptive. And just like you said, it's the same is true with other pain conditions like chronic migraines, fibromyalgia, chronic musculoskeletal pain, even other conditions that don't involve pain, like chronic dizziness, postural orthostatic tachycardia syndrome, or orthostatic hypotension, meaning that, with changing of position, the heart rate might go up too quickly, or the blood pressure might drop and you get dizzy. Those are all sort of different symptoms and different problems of the same underlying issue.
The software problem.
Exactly.
Mm-hmm.
Exactly.
Mm-hmm. And you think with COVID, because we know that post-COVID, is part of that category, because the whole world is experiencing a surge.
Yes.
I feel so bad for people in the past who've had, chronic fatigue, all of those kind of problems, and they've been all dismissed. And a lot of them are women too, right?
Yes. Yes.
And they've been dismissed, and now they can no longer be dismissed. The problem is we don't have enough doctors and other, healthcare professionals who know how to deal with it.
Yeah. I think actually this post-COVID or long COVID or long hauler COVID syndrome, all the different terms that it's been given, is actually, in that sense, I think is giving more knowledge to what infections can actually do. And that it brings me a little bit to a point, if I may shift to that, about, how do these disorders of gut-brain interaction or other chronic pain syndromes, but obviously I'm focusing on the Dgbis today, how do they actually come about? And infections in one way actually do play a significant role. And so, the way that we think about it, and the way that we now understand the pathophysiology, if you will, of disorders of gut-brain interaction, are that you have an individual that is vulnerable to develop this hypersensitivity or these false alarms. And that vulnerability, right, is sort of a complicated combination of factors that may make an individual, and in this case a child, more likely to develop chronic pain. And so I'm taking another step back, right, because if we think about false alarms, nerve hypersensitivity, these are all abnormalities in the nervous system that have to do with nerve endings, nerve transmission. And so all of those signals, right, in our bodies are really transmitted from the gut, right, which has its own nervous system. That's a very complicated, intricate nervous system that regulates distension or regulates pain signal. Well, first of all, it regulates how the gut moves and how we feel things, right? Appetite, hunger, satiety, having to go to the bathroom, having to void, all those kinds of things. But it's also responsible for moving things along, for digesting. And then it's also, so that's something we call the enteric nervous system, which then talks to our brain, because a lot of those functions we don't want to be aware of. So it should get filtered out. But a lot of those functions we do need to be aware of, like, okay, I need to go to the bathroom. Oh, I need to eat because I need to survive, right? So it's a very complicated and complex, is a system of the gut talking to the brain in very selective ways, right? Because we don't want to constantly know what our gut is doing when it's digested. We only want to know when there's something wrong, right? Or when we need to act on something so that we can survive or maintain our weight or feel good, And so hence, right, the gut to brain axis, because the gut, the enteric nervous system in the gut is constantly talking to our brain. And there are, right, the brain obviously has a lot of nerves, the gut has a lot of nerves, and then there's the spinal cord and all these nerves in between that are responsible for the crosstalk. And that's where also the so-called autonomic nervous system, right, then the sympathetic nervous system, the parasympathetic nervous system play an important role. And even other factors like hormones, certain hormones like cortisol play an important role in the gut talking to the brain and vice versa. And so when we think about how a child, when a child develops from in utero all the way up to, their teenage years, all those complicated and complex pathways form. And, we know that it happens from, just a few weeks in utero, these start and continue. And so any disruption of those circuits, those complex circuits that are built and that develop can affect how we feel pain later on.
So when you say interruptions, you're talking about things like illness, but also stress, right?
Exactly. So studies have been done that have shown us like early life events can have a huge impact on developing pain, interestingly, later on with, sometimes 10, 15 years delay. And so the kinds of things, yes, early life events, like, of course, trauma, right? Severe neglect, physical stress, emotional stress, those kinds of things have been actually very clearly associated with development of irritable bowel syndrome and functional abdominal pain later on in life. There are also lots of studies about interventions in babies, in the NICU, frequent heel sticks, that it actually can change the way that pain is processed over time. Kids that have been admitted to the ICUs may have a change in pain processing, frequent medical interventions, severe infections as infants or small children. All those things can affect how the nervous system develops. And
I'm sorry, but would it also be related to genetics and personality?
Exactly. So that's one aspect of the biologic vulnerability, sort of how our nervous system forms. And then indeed, exactly, there are also genetic components. So we know there's a family history of chronic pain, right? If maybe somebody else in the family is sort of wired in a way that unfortunately makes them more vulnerable to experience pain. Or if somebody actually has a disorder of gut-brain interaction, that also increases the risk of a child to develop it for reasons that we don't fully understand, but we know that that's a fact.
Right. What I'm really curious about is colic, because colic sounds like it comes from the gut, but for the longest time we were talking about it like it was really more neurological. And now I'm wondering how we understand colic.
Yeah. So infant colic is basically, right. So it's considered a disorder of gut-brain interaction in babies and infants. And like you said, it used to be thought that it's all about having abdominal pain, right? And the fact is that the way that we understand it now is that it's a disorder of sort of dysregulation, if you will. So something triggers a baby to start crying, and they have a really hard time calming down, right? So that's hence you often get the crying babies, the fussy babies that are very taxing on parents and everybody. Right?
That car alarm, right?
Yes, exactly. It's like that car alarm you cannot shut off, right? Right. And so the way that it may relate to the GI tract, right, is that something often sets these babies off. And it could be that it is, mild distension of the bowel, or that some gaseous distension, or, something else, whether it's milk protein allergy, or whether it's just they're crying because they want to be held. And
is it possible that they're crying? Because I'm always wondering about this. I'm a pediatrician. I live for this. Okay.
Yes.
Is it possible that the crying comes first and then the gut gets distended by the air that they're swallowing from the crying?
Yes. And so then that sort of completes the vicious cycle, right?
Yeah.
The idea is something sets them off, and because they have a hard time self-regulating, they need a lot of external help, right? So it's the driving around, constant rocking, turning on the white noise, like those kinds of things to externally help them regulate. But then, of course, from all the crying, they may also swallow air, which then passes through the GI tract, which makes them more distended, which is one of the potential triggers for infant colic, right? But not necessarily the only trigger, right? It could be anything, being hungry, time of the day, waking up, like anything could trigger them, and they have a hard time calming themselves down. So, yeah, that's right. Infant colic.
Right. And that's also seen in families with a genetic vulnerability more often, right?
Yes.
And the outcome of these kids is they have a higher rate of going on to other Dgbis?
So there's a question of that. So there is a correlation of babies with infant colic that have a family history of migraines. So that is something that's been shown. No clear correlation of them later on having, irritable bowel syndrome or other disorders of gut-brain interaction, but definitely sort of the other way around. We see a lot of times a family history of migraines, interestingly. Yeah.
Interesting.
Yeah.
Okay. So another thing I want to know about, moving a little bit back up to the older kids again, move away from colic, is, parents want to know, how do I know it's not something more serious?
Yeah.
How do we know what's enough and what's too much in terms of a workup?
Yes. So, and just to get a little bit more concrete, right, when we talk about disorders of gut-brain interaction, I mentioned before that the most common symptoms that we see, right, are pain, abdominal pain, either just pain without any other symptoms, or pain associated with eating. So, eating, feeling early satiety, feeling full, feeling bloated, nauseous, all those kinds of feelings. So this pain associated with eating in the widest sense, if it, exists for longer than 2 months, and it happens a couple of times a week, is, so to say, unique criteria for what we call functional dyspepsia. If it's just pain without anything else, it's functional abdominal pain. And if it's pain that's related to defecation, to stooling or pooping in some way, whether it's more diarrhea, looser stools, whether it's more constipation, harder stools, or difficulties going, or whether it's kind of all over the place in terms of bowel movements, but it either gets better or worse related to bowel movements, we call it irritable bowel syndrome, with either constipation, diarrhea, right? And so those are sort of the symptom-based diagnoses that we give for the pain-predominant disorders of gut-brain interaction. Now, of course, there are other conditions that can present very similarly, right? Mm-hmm. You can get bloated and have diarrhea and have abdominal pain with celiac disease, for example. And so that's where part of the diagnostic criteria is that, that we as physicians, right, do a reasonable workup to rule out other conditions that could cause those symptoms. And so, so generally speaking, of course, patients should have some testing done. But the point that I like to make is that it's not considered a diagnosis of exclusion, right? You don't have to check off every other disease under the sun to make this diagnosis. But of course, something reasonable should be done, right? So checking a blood count, for example, to make sure that there's no signs of anemia, which can be a symptom of chronic illness. Inflammatory markers to make sure that there's no systemic inflammation, checking for celiac disease, if there's diarrhea, checking some stool studies for certain infections and for just for inflammation in general can make a lot of sense and should be done, right? And then, depending on what we always look for when we talk to patients and when we take a history, is we want to see if there are any alarm symptoms, right? And if there are alarm symptoms, in addition to those those symptoms that I mentioned that typically, how Dgbis present, then it is indicated to do more testing. And yet they could still have a disorder of gut-brain interaction. And so some examples are, right, if there's blood in the stool or with vomiting, if there's been weight loss, if the child or teenager is failing to grow or go through puberty as we expect, if there's a family history of certain conditions like inflammatory bowel disease or celiac disease, right, that those are sort of what we think of as red flags that always warrant further testing, or trouble swallowing, food getting stuck, those kinds of things are just a few examples, abnormal exam findings, things like that.
Right. What do you say to these families to make it easier for them to accept the diagnosis? Because I do find, there's a resistance to this category.
Yeah. Yeah. In my experience, if it takes time. It takes time and really being present and explaining this very different model to patients, right? And so in my experience, if you take the time, and it doesn't have to be a long amount of time, if it can be just 5 or 10 minutes to sort of summarize some of the things that I've been talking about, can really increase the acceptance, and also feeling comfortable myself, right, with the diagnosis, because I think part of it is also that a lot of doctors don't feel very comfortable and sort of it comes across as a diagnosis of exclusion, or I don't know what's wrong, and so you probably have this. Right?
We've ruled everything out, so I guess you just have IBS.
Exactly. So it's sort of a dismissive diagnosis that patients are given, and I think the important part to remember, and again, more and more research is pointing towards the fact that these are positive diagnoses, not positive in the sense of good, but they're positive, like they're not diagnoses of exclusion, right? They're real. They're very real conditions. And I think saying that it's not in your head, it's not psychological, that is extremely important. And I always feel like patients are quite relieved when they hear that, because it's a very different message that they get from other providers, or even other, schools even, when schools are like, oh, well, there's nothing wrong with you, so you should be able to go to school. Well, I agree, they should go to school because it's part of the treatment plan. And yet, they have symptoms we have to acknowledge, right? That they are nauseous, and we have to work with that. So, and I think that's the difference, right? It's not you have nausea, but you still need to go to school. It's you have nausea and you go to school, right? It's like the two things can happen together.
I mean, I've had some patients with various functional disorders, including IBS, who needed modified school for a while. They were very impaired by it.
Right. So. And I think that leads me to another point that is very near and dear to my heart, is that, I hear so often that patients say, oh, it's all anxiety. And I tell them, you can't, if you are anxious or if there is anxiety, you can't take that completely out of the picture, right? Because anxiety does have its role in exacerbating symptoms, but it's usually not the only cause, right? And patients will come and say, well, some patients come and say, I was told it's anxiety, but I don't have anxiety. I've never been anxious. And so I see some patients that do have underlying anxiety, and the way that I explain it, right, when you think about that parking lot again with those alarm, the alarm going off, what anxiety does, right, it's like putting your hands to your ears and you sort of augment what you hear even louder, right? Mm-hmm. That filter of the brain to sort out what's important, what's an alarm, what's a false alarm, just doesn't work quite as well, because that's what happens in anxiety, right? It's unreasonable. So you perceive things and they just get augmented like that. And so anxiety sort of plays a significant role in maintaining symptoms and in potentially aggravating symptoms, but it's not necessarily the only cause. And then the other part I see is that probably about 50% of patients I see, they actually develop anxiety as a result of the symptoms, right? I don't want to go to school and have to run to the bathroom 5 times because I have diarrhea and everybody sees me. So they develop anxiety about going to school. And that nuance, I think getting that across and making families understand that there are those two sides of anxiety. And yet, sooner or later, anxiety usually plays a role, whether it sort of came first or came second, but it plays a huge role in then maintaining the symptoms, right? Because then you're not going to school, you're anxious, you get even more anxious when you have to go to school. That's going to worsen the symptoms. And so before you know it, you're caught in this vicious cycle. So anxiety needs to be addressed. It has its role and its place, but it's not everything.
Right. I want to go back a little bit about the anxiety, because I feel like we bent over so much backwards to say it's not all in your head, then we can ignore that there can be pre-existing anxiety. What percent would you say have pre-existing anxiety? Not necessarily as the cause of it, but maybe associated.
Yeah, so we've studied this in our population, and it's always a little bit tricky because unless you have a psychiatrist that sort of formally diagnosed an anxiety disorder. So if we say patients that have reported a history of anxiety, right, of what, sort of generalized symptoms of anxiety or anxious about certain things, even if maybe they don't meet criteria for GAD, right, generalized anxiety disorder, about half.
And compared to the general population, I feel like all teenagers are anxious. So it sounds about.
Yes. Yeah. That's a good question, actually. I mean, the prevalence is definitely higher. It's definitely higher among patients, and that's been shown, among patients with Dgbi, closer to 60 to 75% if you look at, depending on what data you look at.
Right. So what you're saying is it's higher, but people need to understand that it's not the cause of, and the disorder itself can create, it's an interaction again, right? It's
exactly
brain-gut interaction. So it can go backwards and forwards. And that brings me to how important it is for the physician and the parent in terms of how they talk about it, right? In terms of how it's being diagnosed. Because I know you mentioned in your talk about how when doctors do so many tests that can actually ramp up the anxiety. Something's wrong with me. What could it be?
Right. And so that's twofold, right? One is the patient's anxiety. So patients get very anxious. What's wrong with me? The school part, or sort of the social part of the symptoms. It's the worry, what do others think of me because I don't have a real disease, right? So we have to sort of debunk that for them. And then, the way that I usually like to say it is that it's not all anxiety, right? But you can't take anxiety out of the picture because it plays a huge role in sometimes bringing on symptoms and sometimes maintaining symptoms. And I think that's where, I really try to understand, in some patients, it plays a significant role. And in some patients, it really, they after a while, when they start learning about their symptoms, they can actually say, my nausea flares when I get anxious. But it's just not like that for all patients. And I think that's really important to be fair to them to understand. Right.
It's not like that it doesn't play as big a role, or they just don't see it.
Exactly. It doesn't play as big of a role. Right.
Everybody's
different. And that's where I think, we are now learning that in the Dgbi, sort of to go back to when we started talking about sort of what the role of infections, right? We talked about the biologic vulnerability. We talked about early life events and how they affect the nervous system. And the one thing that I didn't talk about yet is sort of also the genetic predisposition, but also the environment, right, that children grow up in. And so modeling, right, whether there's an anxious parent that overly pays attention to certain signals or certain symptoms in themselves or in the patient may also influence, right? And all those factors together is what we think of as the biologic vulnerability. And then if something sort of happens, right, what we call in the medical terminology a sensitizing event, and that can be an infection, it can be stress, it can be an anxiety-provoking event. Again, here's sort of anxiety plays a role, that then sort of brings these symptoms to manifest, or makes these symptoms manifest, like an iceberg or a volcano that kind of erupts. And the most common sort of cause to trigger symptoms of Dgbi are infections, right? To get back to where we were in terms of COVID is I think now it's sort of obviously a popular thing that we all read about, but it's been long known that if you have a gastroenteritis, whether it's, a parasite or a virus or even bacteria, that a lot of times your body clears the infection, but the symptoms stay, sometimes for weeks, for months, right? And so you have this irritable bowel syndrome that persists. And we've studied this in our group, and it's not just actually GI infections, gastrointestinal infections. There are also other infections. So non-GI infections, whether it's urinary tract infections, throat infections, EBV, right? Mono, as a classic example, and other infections that can then actually trigger GI symptoms. And then we've also, seen stressful events, right? Major life events, stressful events that can trigger this to manifest. And then even concussions, injuries, musculoskeletal injuries, a major surgery, or the diagnosis of an organic disease. Patients are diagnosed with celiac disease or Crohn's disease, and it gets well controlled because they're eating the right diet, they're eating a gluten-free diet, they're getting treatment for their Crohn's disease, and yet symptoms stay to some extent. So their body has gotten sensitized and they have ongoing symptoms of Dgbi. So you can see, right, it's tricky. Sometimes there's even an overlap, right, of organic, so to say, hardware problems and hardware problems sort of triggering software problems.
Right. What about antibiotics? We haven't mentioned, but everybody's talking about antibiotics and how they affect the microbiome, which you really need to talk about the microbiome.
Yes. So, well, I mean, the first question is it really the infection, or is it sometimes the treatment that can set up a disorder of gut-brain interaction? But that's I think still the verdict is still out there. We don't know. The microbiome. So I talked a little bit before about the gut-brain axis, right? And if we're technically correct, the technical and correct term really would be the microbiome gut-brain axis, because you can't take the microbiome out of us, right? And so we know that patients with, again, the most well-studied Dgbi is irritable bowel syndrome, so that's why I'm referencing that a lot. So we know that in patients with IBS, irritable bowel syndrome, versus patients that don't have IBS, their microbiome is different. We don't understand yet fully what that means, what those differences mean. And so we also don't know how to manipulate it to make it, to treat the microbiome to relieve the IBS symptoms. But they have done, in animal models, they have sort of disrupted the microbiome and created symptoms of irritable bowel syndrome, for example. And so that is, it definitely plays a role, right? And we also know that some probiotics can actually help relieve symptoms of irritable bowel syndrome. So it definitely plays a role. And we unfortunately don't understand it well enough yet to target that as a specific treatment. So we treat it in a more general way. Now, the microbiome gets disrupted with either sometimes infections, right? Like a viral gastroenteritis can really disrupt the microbiome, and of course also antibiotics, right? And just for all the listeners, right? When we talk about the microbiome, we're talking about all the millions and millions of bacteria that live in our gut that need to be there to regulate our immune system on the one hand, right? And on the other hand, also to help us digest, actually, for certain nutrient absorption. It's important for bile acid metabolism. Like for a lot of digestive processes, the bacteria are actually really important. And it's sort of the idea is that it's many different bacteria, and they live together in a way that makes it work. And when that gets disrupted, you can have all sorts of problems, right? Sort of in a very general sense. And so the thought is that with antibiotics, we know that with antibiotics, the microbiome can get disrupted, right? Certain bacteria also get killed off with the antibiotics, just like the antibiotic kills off the bacteria it's supposed to kill off, right? And so in that way, antibiotics can trigger symptoms of irritable bowel syndrome as well. So
right, and why you don't want to take antibiotics for a viral illness if you don't need it. We're learning more that a lot of even bacterial infections, like ear infections and sinus infections, can go away without antibiotics.
Yes.
But on the flip side, if you need them, and you'll figure it out. There was a very interesting book. I don't know if you read it. It's called Reimagining Chronic Illness. It's called The Imaginary Kingdom, Reimagining Chronic Illness by Megan O'Rourke. And in that book, she has chronic Lyme, which, chronic Lyme is sometimes a diagnosis given to somebody with chronic fatigue, but in her case, she apparently did have some interaction, and she had, IBS symptoms too. And she ended up being terrified to take antibiotics because she'd been always told, your microbiome, your microbiome, your microbiome. And she ended up needing the antibiotics, and then she ended up having a fecal transplant.
Yeah.
So it's a very interesting book.
Yes. Yeah, there's a lot of ongoing research about things like, fecal transplant. So literally transplanting somebody's, presumed healthy microbiome into somebody else's gut.
Yes.
A poop transplant, literally. Not a standard of care at all yet in irritable bowel syndrome, but in other conditions, like if you have certain types of recurrent infections, like Clostridium difficile, C. diff, for example, that's actually something that's now done and has been shown to help. But it has its, limitations too, and other things, like it can trigger some inflammation in the gut and other things. So it's, it's not something we routinely do at all for irritable bowel syndrome. But yeah.
Great. Yeah, it's very interesting, but she was suffering from infertility and horrific chronic illness, and she ended up getting better from a combination of those antibiotics for that chronic infections, and then later the fecal transplants, and she was able to have children. So it's an incredible journey. And she also talks a lot about how hard it is to be treated like you don't have a real disease.
Yes.
Right, when you can't measure it. So a lot of what we've been talking about.
Yeah, but to that point, perhaps also, and I think we'll get into the treatments a little bit more, but we do sometimes use antibiotics to treat what we call bacterial dysbiosis. So if you've had an infection and it sort of did its havoc in your GI tract, and it maybe destroyed some of the good bacteria, we sometimes actually use antibiotics, some of the names like Flagyl, metronidazole, or rifaximin, Xifaxan, to actually deliberately redistribute the bacteria in the gut. So we also use antibiotics sometimes for treatment, even in irritable bowel syndrome, but it kind of goes both ways, right? They're a risk to cause symptoms, and yet sometimes we use them to treat.
Right. So let's talk about the treatment. If you want to, we can start with that overgrowth, what's called small intestine
bacterial overgrowth. Yeah, SIBO. Yeah.
How would you know you have that? I haven't had patients being treated for that.
So maybe just to put it in context, right? When we think about the disorders of gut-brain interaction, we talked about those key things that are wrong, right? The visceral hypersensitivity, oversensitivity of the gut nerves, of the sensors, and or the motility, and then also this other factor, right? That's the gut part, the part of the brain that's overly aware, something called central sensitization, right? And the way that I sometimes describe it to my teenage patients, which they always understand, it's like that friend that just is constantly texting and you can't make them stop. So it's this over transmission of signals to the brain as well, right? So those two concepts, visceral hypersensitivity, oversensitivity of the gut, and central sensitization, which is that hyper awareness of what the inability to filter, right? It's like putting that, not on purpose, but putting those like big ears on your ears to make things even louder, or hear things even louder. Those are the key mechanisms that end up resulting in the symptoms. And so when we think about treatment, we think about, we want to address all those aspects where things can go wrong on the gut-brain axis. So that's the gut itself, and it's also the processing center, right, which is the brain. And the other thing that we try to identify and that we try to understand, is there anything that is triggering symptoms? So for example, we know that bacterial dysbiosis, or SIBO, small intestinal bacterial overgrowth, is certain types of bacteria have overgrown, or there's too much of certain bacteria, and that can cause more gas, right? And gas causes distension. And in somebody that already is sensitive to a little bit of distension, when they get distended, they immediately feel this huge pain signal in their brain. And so those are the kinds of triggers. Like, we don't think of it as the cause of IBS or the cause of a Dgbi, but we think of it as a trigger, right? The gas from bacterial overgrowth in somebody that is predisposed to experience chronic pain is going to, the littlest bit of distension is going to cause a lot of pain. And so we may want to treat that trigger.
How do you know you have that though?
So there are tests for it, right? There is a so-called breath test that's pretty easy to do, where patients breathe into a device, and then depending on what is exhaled, well, first you drink a certain solution, and then you breathe into a device at specific intervals, and depending what is found in the exhaled air, you can meet criteria. You have or don't have or meet criteria for bacterial overgrowth. It's not a perfect test, right? There are reasons that it can be falsely positive or falsely negative, but it's an easy test to do, right? I just always caution that, even if the test is positive and we treat it, it may not make all the symptoms go away. And patients, do tend to focus on an abnormal finding, and then that's the cause. That's the cause.
That's it.
Remember,
we did
right.
it.
Remember, and it may help, but remember, the cause is that underlying hypersensitivity and not the one disease that's causing the symptoms, right? And so the way that I generally think about treatment of Dgbis, and it's like a balloon with many holes, right? And you kind of have to patch all of them. And in some patients it might be 2, and some patients it may be 10, and you have to address all of them, and to keep the balloon inflated, and then you can sort of take off one after another to hopefully make sure that the balloon stays inflated, right? And that I think also is sort of, to just backtrack again a little bit before we get into the treatments in more detail, is when we think about acute pain, right lower quadrant pain, get an ultrasound, get labs, maybe a CT, you have appendicitis, you take out the appendix and it's done, right? That's what we call the medical model of disease, right? It's very straightforward. And we as in the medical world are very good at that, right? We have really good devices to test for those things. And then we have this, so that's acute pain, right? The harmful pain. And then we have this, what I would consider hurtful pain, not dangerous pain, but it's that false alarm pain that's constantly going off, and that's more chronic pain. And chronic pain meaning, right, if you've had pain for longer than a few months. And that pain it's not an alarm signal of an underlying disease that needs to be uncovered. As you can tell, I can't emphasize that enough, but it's the constant false alarms. And that symptom of pain is much more complicated and complex, and many more factors play a role, right? And kind of similar to what causes these symptoms, similar factors like, if there is anxiety, it tends to be perceived more intensely. Some patients pay more attention to it than others. Modeling in the family plays a huge role, right? Like, if somebody else has chronic pain, the child might react differently to their chronic pain. Kids have different coping mechanisms. All of those things play a role in whether or not chronic pain stays and how much it affects people, and how, or children, adolescents, and how affected they are, and sometimes disabled they are by it.
So I think the interpretation of the pain in any chronic pain syndrome is so important. I'm wondering whether family therapy could help, because it's not just the child's perception, it's also the parents.
Yes. And that we know plays a huge role, and is also part of treatment, right? And to that point is because it's not just the child, it's the family, it's school, it's the doctors, it's whether they had, it's all these factors. And that's what we, as opposed to the medical model, right, what we call the biopsychosocial model. And so that concept is really important to understand when we think about treatment of Dgbi, because we can't just treat that one thing, right? We have to see the whole patient. And I think that becomes more obvious and more important, then we kind of know that we always need to take the whole person into account. But in these conditions, these chronic conditions and chronic pain, it's an absolute must. And sometimes that can be simple and sometimes it can be very complex, right? And so that's where, if you think about sort of the biologic, right, biopsychosocial model, so biological factors we talked about, right? So those vulnerability factors. And then we have the social or the psychosocial, so right, the psyche, the mental health, the psyche of the person, right, plays a huge, and that means coping mechanisms. It means how they react to pain, how resilient they are, and then the social environment, of course, is modeling and those kinds of things that we talked about. And that's where definitely the parental, the way that parents approach the pain of the child plays a huge role. And they've done some studies where they've had patients with functional dyspepsia. So again, pain, discomfort with eating, often a result of just a little bit of distension of the stomach, experiencing a lot of pain. And so they've had, they did a so-called water load test. So they had these teenagers drink a bunch of water pretty quickly. And all patients that had functional dyspepsia, and they all had pain, right? Because they very quickly filled their stomach. And then the parents or mothers in this case were randomized to two groups, one to pay attention and sort of feed into the pain and say, oh, I'm so sorry, you're having pain. And the other group was randomized to distract and not pay attention to the pain. And what the study showed was that all mothers felt it was completely inappropriate to not respond to the pain, right? To distract, because that's what we do, right? As mothers, we feel with our children, and we want them to feel good, and we sort of want them to rest if they have pain. We would try to make it better, but in that sense, we also feed into the pain and give it more weight, if you will. And so what the study ultimately showed is that those teenagers where the mothers distracted them had lower pain scores at the end of the water load test than those where the mothers fed into the pain. And it just shows, right, that again, with chronic pain, we take it seriously, we acknowledge it, right, but we react differently. It's not the kind of pain that makes you, that you should lie on the couch with and recover until you feel better, because you can wait a long time and you lose your life if you do that, right? It's more of, coping and living with the pain, but acknowledging that it's real pain, right? Similar to, if you've broken a bone and it's in a cast and the cast comes off, first it's hard to move and it might hurt a little bit. And so you get physical therapy, and with guidance, you move until you're back to your baseline. And so that sort of similarly, applies to Dgbis, that we want to continue to use the body and ourselves and function rather than withdrawing, because that will just make everything worse. It's actually a really important part of treatment.
Right. But when you have these problems, they're going to be up and down, unlike a broken bone that heals and then you're done. There's no linear progression. There's ups and downs. Yep. And so I think that what the child has to learn is how to, like you said, live with it. So how can a parent help? We really talked about how they could make it work.
Yes. Yes. So, again, coming back to sort of the overall big treatment philosophy, if you will, right, is that we take the whole patient into account. So I think the most important thing is for the patient and the parent to understand this biopsychosocial model, to understand what these Dgbis are, that they are real, that they are hurtful, but they're not harmful, that they're very disruptive, right? And that education is absolute key, right? And really should be, as soon as we even think about a disorder of gut-brain interaction, that concept should be introduced, because it's very new to most people, even physicians, right? Because it's not the medical model that we're so used to, and that we as physicians also are trained in so rigorously. And so the education, and that's where I think the first thing is that parents, there has to be buy-in. And with buy-in doesn't mean that I'm trying to convince you. It's more that, I offer the explanation of what research has shown, so that, hopefully you understand the disease the way that we currently understand it. So I think that's the first, very important part. And then the other part is, of course, we use treatments that medications to treat symptoms, either symptoms, so calming those nerves, reducing the crosstalk between the gut and the brain, desensitizing in a way the system, right? And so those are all sorts of different medications that I won't go into details that act on the level of the GI tract or on the, the central nervous system, the brain. Certain herbal supplements, medications against cramping, like all those kinds of treatments. And then we have, a whole group of interventions that are non-pharmacologic, so that are not medications, that are, in my mind, equally and maybe even more important. And so the key is, you have one individual that comes with their, we know that they have this hypersensitivity, the central sensitization, but the triggers for each are different. So there might be a patient that, diet is a trigger for the symptoms. There might be a patient that has bacterial overgrowth as a trigger, but that's not the same for everyone. And so that's our job as a physician, to try to tease out what the triggers are. And triggers, and that's also where parents can be very helpful, because they're very good at observing, right? Is anxiety a trigger? Right? So a trigger, right? The role of anxiety, it's not everything, but is it a trigger? Was there an infection, like a cold that sort of caused a setback? Certain food stressors, like those kinds of things, that it's important for the patient to get to know themselves, and for parents to sort of pay attention to try to figure out those triggers. And then we can address those. And so those are sort of patient specific, but then there are also the treatments that we, recommend overall, like lifestyle changes, which always sounds so simple, right? But it's, I truly and genuinely believe it's one of the most underprescribed interventions, right? Anything that generally makes us feel better, sleep hygiene. It's a huge issue with all the screen time we all have, with all the things that are happening in the world, for teenagers also, right? Poor sleep, like it opens those gates to allow more of those signals to flood into the brain, right? So sleep, exercise are really important. And if a patient struggles to even walk around the block because they're having such severe pain, which may not always be the case, but sometimes it is, then, getting guidance maybe from a physical therapist can help to sort of slowly recondition them and rehabilitate them. And then we kind of pick and choose from many different things, right? Like that balloon with many holes of the kinds of interventions that we offer, from dietary interventions, from psychological strategies, right? Most of them we borrow from cognitive behavioral strategies. So it's not necessarily the type of therapy where we think about patients, talk therapy, talking about what bothers them and what, happened today. It's very specific, learning very specific strategies to turn down that signal, right? And I like to explain, it's like being in that parking lot and sort of covering your ears as opposed to extending your ears to calm down the signal. It's like putting that phone aside so that friend can't constantly text you, or putting it on mute. So learning concrete strategies to reduce the crosstalk between the gut and the brain. And that's where also things like hypnosis, relaxation strategies also have their role and have actually been shown to help.
Right. Can we talk about diet?
Yes. Yes. So diet can be a very key part in treatment. Again, I always warn, not always, and we always have to be mindful, right? We only want to have patients on treatments if it's actually doing something for them. And so there are a number of different dietary interventions that can help patients with functional dyspepsia, with irritable bowel syndrome, sometimes even with functional abdominal pain, but mostly with functional dyspepsia and irritable bowel syndrome. And there are different ways of approaching that, right? So we know that greasy foods, fatty foods, sometimes really patients, with these Dgbi really struggle with them. We know that lactose, right, milk sugar, lactose intolerance can be a trigger, again, right, a trigger. It's not the only cause, it's a potential trigger. We know that sometimes high amounts of fruit sugar can trigger symptoms because they, the bacteria or the the sugars might not be fully digested. And then there's some, fermentation in the gut, and it creates gas. And again, you have distension, pain, symptoms, diarrhea. And so, so these are sort of specific things that can be tried. Gluten for some patients, right, can be a trigger, not celiac disease, but just what we call non-celiac gluten sensitivity, that they don't get inflammation or irritation of the bowel, and yet they still struggle to tolerate. It still gives them symptoms, right?
Right, and this is not something that you can measure. This is something that you have to do an elimination diet for. Exactly.
And then, the most well-studied sort of diet, that's not a diet for weight loss, but a diet for symptom control, is what has become known as the Fodmap Diet, which many of you may have heard about. It's an acronym, right, that stands for different things. So, for fermentable oligosaccharides, disaccharides, monosaccharides, A stands for and then P for polyols. And so these are basically all poorly absorbed, osmotically active, rapidly fermented kinds of sugars, carbohydrates that can cause symptoms. And so when it's hard to tease out exactly which food it is, it can be helpful that patients, and I always recommend under the guidance of a dietitian, to try this full elimination diet to eliminate a lot of these foods, right, which include basically gluten, onion, garlic, honey, milk, sugar. Like, it's pretty restrictive, with the idea that once you're on this diet, then if you feel better, you know that the diet is a potential trigger, and then you start reintroducing very slowly to identify the foods that are, triggers for a specific person. The idea is not to stay on this diet forever.
When you say elimination, you're not talking about the FODMAP diet. You're talking about even more than that, right? Because gluten's not part of FODMAP, is it?
Well, yeah. So gluten is part of the, so fructans, galactans, and gluten. It's because, so gluten is essentially part of the FODMAP diet, but not as strictly. Like, there's certain forms of gluten that are better tolerated. For example, if you eat sourdough bread as opposed to yeast bread. So there are, and usually a little bit of gluten is okay, but large amounts of gluten aren't. But a strict FODMAP diet initially would be almost gluten-free. But again, the idea is not to keep patients on it, but to reintroduce, to have them eat as liberal as possible and identify the triggers. And there are these sort of, as you can see, two different approaches: either eliminating sort of the highest yield foods, right, which is milk, sugar, garlic, onion, greasy foods like that, or doing the full elimination diet as in a FODMAP diet, and then slowly bringing things back in to help us tease out. And I just have to always caution that with these dietary interventions, we see it go both ways. For some patients, it helps, but it can also sometimes, and not infrequently in teenagers, actually create anxiety about eating, right? Because they get very, very much stuck on the idea there's certain foods that are causing symptoms, so I need to stay away from them, and they get afraid to eat them, and sometimes even develop what we call avoidant restrictive eating. Right. So we just always want to be mindful.
Yeah, I'm sorry, there's also orthorexia as well in that book that I was talking about. She spent her entire every waking moment taking almonds and getting the skins off and making milk out of it and whatever. She had nothing else with her life, and she'd had no friends. It was in and of itself became a disorder.
Yeah, and that's something that, why I always say, we have to be very mindful and check in frequently with patients to make sure that it doesn't take on those extremes. And then also, right, it can be a slippery slope to really develop a disordered relationship with eating, and even into an eating disorder. And so it's just something if it helps, great. And we want patients to avoid the foods that are triggering their symptoms. But we also want to really be mindful to reintroduce things as quickly as we can, because it's usually not all those foods that are bothering them. It's usually a few, if that makes sense.
Right. Do you work as part of a multidisciplinary clinic? Because what I'm hearing from this is you really need a multidisciplinary approach.
Yes. So I do at Boston Children's Hospital. We have what we call the the Functional Abdominal Pain Program. And it's a multidisciplinary program where consisting of a gastroenterologist, pediatric gastroenterologist, a psychologist that's specialized in GI really, with a pain physician, we have a dietitian and a social worker. And so when we see patients, we sort of see patients all together and then also provide input on the treatment from all different aspects, right? And of course, that's a luxury to have, right? That's not always available, right? There are only very few centers that have those kinds of teams assembled and available, but also not all patients need that degree of support, right? And that's where I think it's also important, right? There are some patients that have very mild symptoms, but they have symptoms, and some but they're going to school, they're functioning, they're playing their sports, they're seeing their friends. And then we have the other spectrum of patients that are severely disabled by their symptoms. And that's where in sort of my mind, that's how I judge the severity of DGBI, is really how much is it affecting their day-to-day life and activities. And also their mood, right? Like this can be very taxing, and patients can get depressed because they're having such severe symptoms and having to live with those symptoms. And so depending on how much it affects their life, their day-to-day life, that depending on that is sort of how I recommend to judge how much support they need. And, if a pediatrician has a therapist in the practice or a dietitian, like those can be pulled in, or a lot of it, physicians can also do on their own, right? In terms of prescribing some of the medications or referring.
Right. I mean, my problem is, as a pediatrician, I have 10-minute visits. Yeah. Not only not multidisciplinary, it's really just not adequate time for something like this. And what I do is I just do a lot of referrals and I try to coordinate them.
Yeah.
I don't have a better answer.
Yeah, I mean that of course is right. When we think about when we see patients in our clinic, right, we have an hour, so we can really to take a history and then go into a lot of this. And so sometimes that's what's needed, right? You refer because that's what we do, and we have more time dedicated to talk about all these things and provide the education. But it's certainly not something that can be, sort of quickly fixed because it takes a lot of education. Right. Or you can also do it in pieces, right? And sort of talk about it, emphasize it again. But for those listening that are physicians, right? The one thing that I do think is very important, if you even consider that a patient is presenting with symptoms that could be consistent with irritable bowel syndrome, for example, mention it very early, because it really should be part of your, what we call differential diagnosis very early on, and really not a diagnosis of exclusion. And it really helps.
Right. What I do is I like to say from the very beginning, because we know we're going to do other tests. And I'll say, I'm not saying this is, all in your head. This is real. We might find something. So we're going to look. We're not going to dismiss it as something we already know is functional or whatever term you use. But I say it right from the very beginning, because I think it is so important for them not to be holding out for that, yes, medical, magical.
The Holy Grail.
Yeah, the Holy Grail. Yeah. And I love that idea that you talked about, and you were talking about the golden half hour of diagnosis. Yes. If you want to spend a little more time telling the physicians out there why this is so important.
Yes. Yeah. So it gets to the point, right, about the education. So golden half hour, right, which we know from other emergency situations, from trauma, sepsis also, right, of like what needs to happen in that first half hour or hour to have an impact on patient outcome. And so some of my colleagues have written a beautiful piece that was published in the last year in JAMA Pediatrics, actually, that sort of summarizes that golden half hour, or they sort of bring up an analogy of the golden half hour in chronic pain. And basically, the importance of the education, right, the explanation of what chronic pain is, and also of this acknowledgement and conveying that it is real, right? So that's what that, golden half hour, or maybe even only golden 2 minutes or 10 minutes is, right? But the importance of early education.
Right. You're acknowledging it's real. You're acknowledging its impact. And I also like to give hope. I like to say that we're going to help you feel better.
Yes.
So that instead of they're waiting for the diagnosis, so then they can get the treatment, and then they're disappointed when they don't get that, you're saying, I think the tests are going to be normal. We're going to make sure. And I'm also going to make referrals because, again, I only have 10 minutes, right? Yeah. It's not enough.
Exactly.
But I try to give that hope because I think it's so important for them to hear that.
Yes, hope and also setting expectations, right? That this is not a quick fix. This takes some teasing out of, what their triggers are, what triggers them, but that they will get better. And I think that's also a really important aspect, right? That this is something that does get better with, the treatments that we talked about. And another way that I sometimes explain, the analogy of sort of software and hardware that we talked about in the beginning, right? That these are software disorders, and we sort of look at the hardware. But sometimes, when you have a software, when your computer software has a glitch and everything freezes and it drives us crazy because the computer doesn't work. If you were to open up the computer, right, everything looks normal on the inside. But you might find some dust here and there, right? And that, I guess, dust could affect how the computer functions. It usually doesn't, right? So we may find things along the way that may or may not contribute to the symptoms or be triggers of the symptoms. So that's just another way that I like to explain it, that I think resonates with a lot of patients.
Right. There you have so many great analogies, and we could talk about this all night, but I told you an hour. And we didn't even get into, at some point, I think I'm going to do a conversation with someone about alternative treatments to it, because we didn't really talk about how some people find help with alternative treatments. I mean, in my mind, I just want my patient to feel better. Yes,
there absolutely are, things out there that, and there's growing evidence that alternative medicine or complementary alternative medicine does help. And so acupuncture is one of them, right? That's been being studied more and more. There are certainly herbal supplements that can be helpful. There's another new device, right, that some of you may have heard about, the so-called IB-Stim. It's a neural stimulator. So it's a little nerve stimulator that gets attached to the ear. And it's basically doing a little bit of electroacupuncture of the ear, and it affects the vagal nerve, right? And the vagal nerve is a big nerve that's very important in regulating internal functions, from heart rate to digestion, and pain sensation, feeling when the stomach fills and those kinds of things. And so it's a device that it's non-invasive, but it stays attached to the ear, battery operated, and it's been shown to reduce pain in patients with IBS and now also with other Dgbi. So there's lots out there.
Wow. Is that an external vagal nerve stimulator similar to the internal one for seizures?
No, it's not just specific to the vagal nerve. It's some more peripheral centers of the vagal nerve that are affected, but no, it's not as, it's different. Yeah, because it's more superficial, right? It's not implanted.
Right. I mean, I think the bottom line is we're going to learn more and more. This is more and more people are having these kind of problems, so we're going to have to learn more and more. And I just want to say to parents out there that you're your child's best advocate. And build your team, because I do think this needs a team approach. If you don't have a center like you're so fortunate to be part of, as a parent, you can still find your professionals and put together a team.
Absolutely. And also help explain these things to the school, right? Mm-hmm. And that's where, whether we as physicians can provide it or not, write a letter or something for the school to explain, that what these disorders of gut-brain interaction are, that they affect patients, that the symptoms can wax and wane, that they may need some accommodations to help them reintegrate into school, and also teaching teachers how to react to somebody who has chronic pain, and how to send them back to class and how to keep them in school. And so that's definitely a process that takes time and effort. And that's where parents absolutely, once they understand the concept of treatment for these disorders, right? Because again, it's not always intuitive. And it can be very, very helpful. And absolutely, like you said, be strong advocates for their children.
Right. And ask your doctor to write that letter. That's part of your advocacy. I don't care if it's the gastro or the pediatrician, make somebody do it.
Right.
Really important. All right. Thank you so much for doing this with me. This has been amazing. I really appreciate it.
Thank you so much for having me.
Thank you.
Bye-bye.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.